Okay, so good morning, everyone. Today we are going to talk about a very important thing that we should all know. Because a while ago we had a chest X-ray. The patient have had a central line in it, and no one of the attending residents knew what that was. So this made me thinking there are a lot and a lot and a lot of tubes, catheters, shunts, plates, screws, prosthetics, joints, and a lot of other different things that are being used in modern medicine and surgery. And we as radiologists need to know what these are. We have to report it in our reports. There is a tube, there is a shunt, there is a plate, there is a screw, there is an I don't know what. So our colleague, Dr. Adina, has prepared something nice. I saw it. It's very nice, very interesting, but I think it will not be enough in one session. So we might need to do 2 or 3 sessions to cover the whole thing. Okay, you can start, Dr. Adina.
Good morning, everyone. Thank you, Dr. Ahmed. Actually, when I started preparing this topic, I thought will be end in 1 week, but I found that it's more extended than I thought. So I found myself defining this topic into 4 parts. I hope, as I said, Dr. Ahmed, to cover it in 2 or 3 sections. So we'll talk about the tubes and the lines for the neck, chest, and abdomen in pediatric patients. Then we'll jump into all the cardiovascular implant devices and tube, everything related to the cardiovascular system. The third part will be also divide and stents. This is an adult patient for the neck, spine, and chest and abdomen. And finally, we will cover the orthopedic devices and plates for starting from the head down to the pelvis and extremities. So starting with all tubes and lines in pediatric patients, we will see the umbilical artery, catheter, and vein, the central venous lines, including the peripherally inserted ones. We will see the endotracheal tube, chest tube, and extracorporeal membrane oxygenation. And we will see the NGOG tubes and gastroschisis bags. So starting with the umbilical lines, we all know there are 2 types of lines. There's the arterial one and there is the venous one. So starting with the umbilical artery catheterization, it is very important in neonatal patients, those in neonatal intensive care units. It to provide a direct access to the arterial system, allow accurate measurement of the arterial blood pressure, blood sampling, give us a good intravascular access for all the fluids and medication. So for the neonates, the normal pathway, the umbilical artery consists of anatomically 2 arteries and 1 vein. So the catheter will be inserted through the umbilicus into the artery. Whether it is entered into the left or the right side doesn't matter. The important thing is the direction of the catheter. So it will be flipped down, enter from the umbilical artery into the internal iliac, and then to the common iliac, and then go up into the aorta. Sometimes it goes from the other side. Now, through this umbilical artery, sometimes we might face problems. Now, the important thing is the position of the catheter, and especially the tip, which we should focus on when we report our reports. The tip, it should be either in higher position or in lower position. Meaning by higher position, it should be above the celiac trunk, the supramesenteric artery, and the renal artery, and meaning in high position, reaching up to thoracic vertebra 6 to the thoracic vertebra 9 level, or it is lower than inferior mesenteric artery level L3 to L5. The purpose of this is to advisable to avoid as much as vascular complication as possible, because this is where we might have complications. So either it is in high or a low position. Okay, next.
Just click on.
Okay. So one of the most common complication is the malposition of this line. This patient had 2 lines, the venous and the arterial. Let's avoid now talking about the venous, focusing here on the arterial one. You can see here it has been entered through the umbilical artery, and as we said, it will go down, entering through the internal, then the common iliac, but as you can see, it did not go up. It is still folded in here. So this is one of the malposition of the umbilical artery line. Umbilical venous catheter, this is much more shorter pathway. It's entered through one umbilical vein, and it goes up directly into the liver. At the liver, it will be connected through the right portal vein, and then through ductus venosus, and then it go up into the left hepatic or sometimes middle hepatic, and then go directly to the IVC, the inferior vena cava. Now, the important thing is that the tip should be above the diverticulum, a few millimeters above it. This is the typical site for it. You should see it. Tip of the catheter.
Above the what?
Above the diaphragm.
Not diverticulum.
Oh, sorry, diaphragm, yes. Above the diaphragm. If it you see lower in here or in here, this is wrong position. As I said previously, this is very important. It can provide us with a good avoiding any painful venipecture for the pediatric patient. It can give us a double or sometimes just like this one, 2 channels of tubes in one tube. This is very good for a child, avoiding painful procedure with a double, triple access through a single lumen. So this is one of the of the problems we face is the malposition. This has entered through the umbilicus and going up directly into the liver, but it's still in the umbilical vein. It did not enter to the ductus venosus, so this is a malposition and we have to insert it more deeply. This is another case where also the venous catheter has inserted. You can easily say this is a venous because there is no the normal folding or flipping down, which we see in the arterial. This is definitely venous. It has go up directly to the liver, but what happened here, it has been entered through the portal, maybe of its tributaries, the the mesenteric veins, and it go down rather than going up. So this is a malposition of the umbilical vein. This is another.
Please, can we see the normal
Yes.
position picture?
Sorry. You can see it go up directly to here. I will show you later also a new normal
You should
images.
see the tip above the diaphragm. If it is
Above
below
the
the diaphragm,
diaphragm.
it's abnormal.
Yes, into the inferior vena cava. Also, this is a case of having 2 catheters. Also, the venous, you can focus here. It has gone up into the liver directly, but what happened is that it flipped through the portal, going into from the left into the right portal vein, going in this direction, and this is wrong. This patient also is having umbilical artery line, which is this one. This is the normal pathway. It has been entered into the internal, then external, and it has gone up to the aorta. This is normal, and it is high position, so there is no problem. Okay. This is another case of umbilical vein malposition. What happened here is that have been passed to the liver through the IVC, and it's go up more enter the heart, going from the right atrium. It has through the this patient had a foramen ovale patent, still patent, so it entered the left atrium, and it have been also entered into the pulmonary vein. So this is definitely a problem. We should reposition it. This is too deep. One of the important, views that help us also to identify the normal position, either in the AP view or if you have face difficulty, we can depend on the cross-table lateral radiograph. This is the baby will be lying on the supine, and we put the tube of the X-ray on the side of the baby. You can easily demonstrate that this is the arterial line. As I said, this has been entered, and this is also the venous, as you can see, directly from the umbilicus to the liver and reaching up here. So this is a normal position. Now shifting into important another yes.
Umbilical artery line, does it need to be above the diaphragm, or where is the
No, as I mentioned, it will be either in higher position, reaching up to T6 to T9.
Right.
The important above this, avoid less vascular complication. If you reach this level from the, let's say T12 enter L2, there is more liability to have thrombosis, for example, or you would injure the renal arteries. So they avoid this site.
It should be either very high or
Very low, yes.
Not from T12 to L2.
Yes,
It's
L2.
wrong.
Yes.
Either above T12 or below L2.
Yes. But this is considered also be normal, because if it is here, this is the problem. Okay. Now the central venous line. The central venous catheters can be inserted in a variety of veins, most commonly including the internal jugular vein, the subclavian, the internal jugular vein, the subclavian vein, and also from the thigh through the femoral veins. Sometimes it can be inserted peripherally through the hand, the veins of the hand, which is brachial, basilic, and cephalic vein. You can see how the catheter looks like. Sometimes also dual lumen, sometimes triple lumen. This is two examples of central venous line. It have been entered through the internal jugular vein, and this is also have been entered through the femoral. This did not reach the accepted level, but just for showing that it will be entered through here. This is how it looks like. The important thing is that the tip of this should be reaching the superior vena cava, or at least at the cavo-arterial junction. So this touching the atrium, not too deep, not too high. Now, one of the, let's say, common things that they face it in the peripherally inserted central catheters, when they enter through the arm, sometimes the catheter tip might move up and down. So, for example, this baby, they abduct his ham and then going back adducting. What happened is that it have been, as you can see, it is more go up and then it descend down. This is acceptable. Now, it has been shown that the upper limb tips should be move up to 2 to 3 vertebral bodies through abduction or adduction of the limb. This is acceptable only in cases of peripherally inserted catheter through the veins of the hand. Okay, so of course, the pathway, all of them should reach the superior vena cava through subclavian or internal jugular, doesn't matter. The important thing is to enter the superior vena cava, reaching the cavo-arterial junction, superior arteriocaval junction. This is the normal site. And roughly it will be at the first intercostal space. Also, one of the famous problems that the male position of the central venous catheter. So this is neonate. He had entering of the catheter through the subclavian vein, but what happened is that instead of going into becoming a brachiocephalic vein and then superior vena cava, it had flipped down and enter into the first superior intercostal vein and through one of tributaries, and then enter into the hemiazygous vein. And when they inject some iodine contrast, they found that it also passed from one of the connecting veins into the azygous vein. So this is, in general, it's the wrong position. This is this case, the neonate, he was in intensive care unit and he had some hyaline membrane disease. You can easily realize the ground glass attenuation, the air bronchogram, they're slightly resolving pneumothorax. He having also some NG tube, which we'll talk about it also later. This is an example of a normal entering peripherally inserted catheter. It have been entered through the subclavian and then reaching into the superior vena cava. This is a normal position. While in this case, there is malposition of the peripherally inserted line. It have been entered through too deeply, reaching into the right atrium, and this is abnormal. Sorry, we don't want this. Now, endotracheal tube. Endotracheal tube, we all know it can help the neonate to especially facing breathing problems. The acceptable, this is how does it look like, and this is an inflating part of it. When they enter it, they inflate it in order to fix in its position. The important thing is to, this tip should be where? When enter into through the airways, it should be reached from the distance between the thoracic inlet and 1 cm above the carina. It's not, we should avoid or focus if it is have been entered more deeply into the shallow right main bronchus, which is one of the famous difficulties or problems they face it. Okay, so this is two examples of malposition of endotracheal tubation. You can see here that it have been entered into the esophagus instead of the airways. This is the esophagus, it have been inflated with air, as well as the stomach. There is a lot of air in here. This is another example. It have been entered more deeply through the carina and start entering into the right main bronchus. What happened here is that the right lung reaching, there is an air, good aeration, but unfortunately the left lung doesn't have any air, so there is atelectasis of this part of the lung.
So in this condition, just by realizing that it's life-saving,
Yes.
they just pull the tube like 2 centimeter, 1 centimeter, air enters into the left lung, complete resolving opacification and fully functioning left lung. Yani your report is life-saving in cases like that.
Okay. Now going to the chest tube or chest drain, we all are familiar with this type of tubes. We use it in residency. So the normal position in the fourth, the fifth, sixth vertebra. Doesn't matter for us. The important thing is to realize it's in normal position. Usually, treating for patients that have a pneumothorax, the direction of the tip should be in the apical superior position. This would be normal, especially in pneumothoraces. So you should be careful looking here if it's not reaching here, it's not too deep, especially in pneumothoraces. One of the types of the chest tube, it's called pigtail catheter. This type can be a very helpful technique, especially for a pneumatocoel, just like in this case, in small effusions, sometimes in pneumothorax, especially of low content. What's the important thing is that it can provide a fixed site, it does not move, and it be placed easily. And when it's easily, it cannot be pulled until there's also specific technique where they open it and then extract outside. So this is called a pigtail when used. So this is not a malposition or calling of the chest tube.
This pigtail catheter sometimes it's called self-locking.
Self-locking.
When you put it in, the tip just curve like that, so it cannot get out of the
Yes,
skin.
yes.
So the baby can be moved so easily, or even any patient
Especially
can.
for neonates.
Even in the kidney, we do nephrostomy using self-locking catheters.
Yes.
When removing it needs some special care, but otherwise it's very useful, very safe.
Okay, now jumping into very important subject, especially for final board examiners, we're facing this type of spot diagnosis pictures, which is called ECMO or extracorporeal membrane oxygenation. Most of us doesn't have any idea about what is this. Basically, the in short way, the idea of this type of system is to provide aeration for the blood circulation for the neonate. When his lung does not function well, he does not get enough oxygen. So what happened is that there they will insert two type of tubes. One of them will take the blood and one of them will bring it back. And they will connect it on a special device that provide with oxygenator, it's called, and they will bring it back to the baby. So this is a very large tubes, and it will done usually in operating room, and it's very invasive procedure in a very critically ill patient. There are two types of ECMO. There is a type that's called arteriovenous, and there is the type that's called veno-venous. For the arteriovenous, usually, they take the blood from the vein, pass it into as I said, into the centrifugal pump and oxygenator, and then bring it back to the body through one of the arteries. So basically, he will have two cannulas, or sometimes one cannula with the two chambers. Veno-arterial. Oh, sorry.
You take it from the vein
and bring
give
it back
to the
through,
artery.
yes.
Okay.
Veno-arterial, yes. Arterial, sorry. The other type that is called veno-venous, where they all take it from a vein and bring it back to a vein. Now, there are two schools of using a veno-venous. Some of them using one vein with one tube with the two chambers, and some of them will use two different veins. Doesn't matter. The important thing is that they provide oxygenation to this neonate. So, this is an example of the veno-arterial type, where they take the blood, for example, in this case, from the superior vena cava, and they bring it back through the carotid artery into the baby. And as you can see here, there is problems. There is grounding glass attenuation. He's unable. He has bilateral pulmonary edema. He's unable to take oxygenation. So this can be life-saving procedure. Okay, this is an example of. I'm sorry, this is typing mistake. This is two examples of veno-veno ECMO. One single lumen with the two channels enter through a superior vena cava. One take the blood and one bring it back from the single lumen. This is another example of two entrants. This is how they look like, and this is how they enter through the body, reaching to the superior vena cava. Okay, so this is an example of a child, a neonate. He had, this is the ECMO line that take the blood, as I mentioned, from the superior vena cava. You can see very wide tube, and it have been connected outside the body through this larger tube. This tube is outside the body, and then enter to do a special machine outside the body, and then bring it back through this larger tube. Then they enter it again through the internal carotid artery. And now this neonate also, he's having an NG tube. I hope it will be clear to you. Very, very line. Also, he's having endotracheal tube, and also he having ECG leads. Yes.
So basically, it's like a lung, right?
Yes, exactly.
Just like hemodialysis.
Exactly.
Sort of
Yes.
it.
Yes, absolutely. All right.
1 to 2 cases about equipment. Now, my question is that how blood return back through
Yes.
artery?
Yes. It's very invasive
If it is
procedure.
artery.
Yes.
It's just replacing, bypassing the lung.
No,
Give the lung time to
when
rest.
the blood comes back from the machine
From the carotid.
to the artery. The
Mm.
artery is the giving case.
No, they put the catheter with the blood flow.
Yes.
Like you do arterial catheterization of the heart, for example. Arterial catheterization, you put it, you can put it against or with, as according to the direction you like. You just put the catheter like that or like that.
Directions.
Whatever you like.
Okay, so gastric catheter, there are two types, the nasogastric or the orogastric. Doesn't matter how they enter it, through the mouth or the nose. The important thing is that the tip should be lying in the stomach, whether not too high or not too deep, passing from the stomach. Other type is called this gastroschisis bag. This is used in pediatric patients who have some abdominal wall defect, where there's no any coverage of the bowel loops. So this is a temporary until the procedure will be done. And this is how they look in the reality, and this is how they look by the X-ray. So this is gastroschisis bag. Now jumping to a very important subject, cardiovascular implants. I hope to cover half of it if I have time. We will also talk about the central venous lines slightly, and then intra-aortic balloon pump, the endotracheal tube, tracheostomy, and implanted device, some pacing wires, some pacemakers, and prosthetic valve. There are central venous lines. There are many types, as I mentioned, including the peripherally inserted ones, the tunneled one. This is all manufactured types. They use it sometimes the tunnel type, which is through the skin directly enter and then reaching into the superior vena cava through the subclavian vein and then the superior vena cava. There is an important type of central venous catheter which is called implantable ports. We will talk about it. So starting with central venous line, this is how they look, and also the same as pediatric. They entered here through subclavian into superior vena cava directly, have reaching this CVC or slightly superior venous junction. This is a peripherally inserted one. From the right side, I hope you can see it, have been entered here and reaching,
Left side.
from the left side, yes, and then it reached into the superior vena cava. This is just a term they use sometimes, PICC line. This is wrong. This is all of it is a part of central venous catheter. Okay, so this is two examples here where they have entered through the right internal jugular vein directly with the tip. You can see it has reached the cavoarterial junction. This is normal. However, in this case, they entered from the left side, and this patient was an unlucky patient. He had two problems. They found there is atelectasis or opacification of the left lung, and they also suspect there is abnormal central venous line. You can see the endotracheal tube also has been entered through the right main bronchus. There is aeration of this side, and there is completely opacification of that side. So when they fix the problem, reposition of the endotracheal tube, and they put also chest tube, the problem of central venous line and demonstrate more clearly that it has been entered through the internal mammillary vein. This is unacceptable. So they will reposition later. This is also another example of malposition of peripheral inserted catheter. They have been inserted. Oh yes, this is the one. Inserted through the cephalic vein of the arm, and instead of going, it has entered the axillary vein, but what happened is that flipped back again instead of going here. So this is one of the examples of malposition. This is another example where the peripherally inserted from the arm, it has been entered too deeply into the inferior cavo-arterial junction, which is the IVC. And this is abnormal, and we don't want that. One of the important things that we see, but we don't know what is this, or sometimes we see the patient's implantable ports. Implantable port, it's a specific type of central venous catheter. It is implantable. They plant this through the skin, and this will be lying under the skin, and then enter directly through sometimes the internal jugular, sometimes directly the superior vena cava into the normal position which we want. Now this is provide a long-term venous access for patients who need medication for a long time, especially for the chemotherapy patient.
Because most of the patients receiving chemotherapy, after a few cycles, the veins will be fibrosed and collapsed,
Yes.
and will be very difficult to have a proper venous access. So what they do, they just put one of these under the skin. You don't see anything from the skin, okay? It's just you can feel the port from the skin, and they cannulate it and inject the chemotherapy every session. So it will be a permanent thing, more or less of a permanent thing.
Yes.
I have one question, Doctor. In preparing this lecture, have you heard about glucothorax?
Glucothorax?
Yes.
No.
Glucothorax occur when the CV line is malpositioned in the pleural cavity. At that time, the fluid will go to the pleural cavity, and it's called glucothorax.
Glucothorax, nice.
So if the central line is malpositioned,
Yes.
fluid will accumulate into the
pleural cavity.
pleural cavity, creating an iatrogenic pleural effusion.
Yes. Glucothorax.
What I read is sometimes. Sorry.
One of the causes of
Pleural
tension pleural effusion.
Nice.
Or
Very
large
nice.
pleural effusion.
Very nice. Sometimes they face problems of hematoma in this side or this side, just opacification on a local side also. This is one of the complications, but it's not life-threatening, just here.
From the glucosaline in front of it.
Nice, thank you. So this port will be sutured, as Dr. Ahmed said, into the skin through these holes, will be fixed, and this will be through the body. There are two types. There's the chest type, you can see this one. This is a magnified fluoroscopic anterior-posterior radiograph of the upper chest, showing there is a subcutaneous chest port and has been entered through the internal, this is subcutaneously. Until here, it has been entered through the superior vena cava, internal jugular, and then superior vena cava into the normal side. This is also another type. They have sometimes they provide a dual lumen interest. So this is one of the example. It's called dual lumen port. You can see two lumens, and this is how they look like by the X-ray, also subcutaneously and directly to the major vein. This is another type. It's called a brachial port. They enter through the brachial vein and how does it look like by the X-ray, and then entered through the brachial vein and then directly into the heart. Another type which is important, it's called intra aortic balloon pump. Sometimes we see this small line which we think this is a calcification or an artifact, and we should ask the patient if he had any cardiovascular procedure before. This is called intra-aortic balloon pump. It provides, give us increased myocardial oxygenation perfusion, and also increase the cardiac output, especially after reduction. In short terms, when their systole will be deflated, and when they're inflated, and systole will be deflated. They use it, but just important for us is to realize the site it should be at the aorta, after the subclavian artery branches. This is how they look like. This is the inflated part. And as I mentioned, it should be located in the proximal descending aorta, just below the origin of the left subclavian artery. This is an example of a patient who had, you can see this very faint.
Of course, just keep in mind, always it will be in the ICU unit. You will not see it in an outpatient.
No.
Okay? And always will be in portable X-ray. You don't see it in the normal X-ray.
Yes, it will be.
Conventional X-ray. Always portable, always critical, always ICU.
Yes.
Always. This balloon pump.
This is another example of this patient had many problems, so I will talk about them. He's having, as we mentioned, the intra-aortic balloon pump from here. This patient also is having endotracheal tube, this one. This patient also is having some mediastinal drain. I hope it's clear for you. He's having some ECG leads, a lot of wires in the X-ray. He's having also a very faint line that entered the stomach, the NG tube. But the important thing also is having this tube that's curving here and then going into the right side. This is called a swanganz catheter. I don't know, the purpose of this catheter is...
It's used for measuring the pulmonary artery
Exactly,
pressure.
yes. Also, they monitor the heart function, the blood flow, the pressure, and everything around the heart. So this is called the swanganz catheter, and this is how they look like. It's a very long tube.
So this X-ray is for a very good board exam case. Just enumerate the leads and the catheters here,
Yes.
and you will fail.
Yes.
والله it is easy.
I hope, inshallah, easy.
يعني doctor, for the first time I thought this is maybe يعني central venous line, but the pathway, the curling into the right pulmonary, from the right atrium and then going to the pulmonary arteries, يعني it's not easy. Okay, tracheostomy tube, we all know the purpose of this, to help the patient with the respiratory problems. So this is how they look in the reality, and this is how they look by the X-ray. This is the curve of it and the entrance here. This is how they look by the CT scan. Okay, so when we see a tracheostomy tube, we should focus on the fracture portion, if there's a fracture or not. So for example, this patient, he had a fracture line entered the right main bronchus. The most annoying is the shallow of this bronchus, so easily it can be entered here. This patient, also unlucky patient, he had a fracture of this portion and it entered to the left main bronchus. So we have not only, when we see this in position, we are happy, no, we should look off if there's any missing fractured. This patient had also tracheostomy tube. He had a procedure called percutaneous dilational tracheostomy. They do for the patient who had keeping on ventilator for a long time, and they want to cause weaning from the ventilator to depend on his own lung. They do this type of percutaneous tracheostomy. طبعا this was unlucky patient, was unsuccessful, and he had also mediastinum from staying in ICU unit for longer time. Pneumomediastinum. Now pacemakers. Pacemakers, we will start hoping to cover it as short as possible. So the pacemaker, we all know the pacemaker, but actually there is the pacemakers and there is implantable defibrillators. Each one has different function. So pacemaker basically for patient having bradycardia to elevate the heart beats. However, the implantable cardiovascular defibrillator is when the patient facing arrhythmia, it will be stabilize the heart more. This is how they look like. And sometimes it's out of the body, sometimes it's implantable under the skin, doesn't matter. The important thing is to differentiate between both. Sometimes it's very, very difficult. Some of them have with a single coil, some of them have dual coil. Usually the pacemaker have dual coil, one of them in the right atrium and the other into the right ventricle. This is in the lateral view, you can see this one in the right atrium, and this is anteriorly, which is the right ventricle. This is a pacemaker. This is an example of patient had a problem, malfunctioning pacemaker. When they did X-ray for this patient, they found there some nodes in here and some nodes in here. There was manipulation of the device, so you can see a knob in here, a knob in here. So this is malfunction. Also, one of the common problem is that the lead fracture. So the leads or the wires sometimes can be fractured and causing malfunction. So very important in X-ray is to look carefully for each wire if there is any filling, any defect. I hope it's clear in here. You can see it is not continuous. Also, this is another example of lead fracture. You can see the defect in here. So this is also a lead fracture. Implantable cardiovascular, usually they have 3 leads, one of them in the right atrium, one of them in the right ventricle, and the other one in the left ventricle. And this is how they look like by the X-ray, and this is how they look like in reality. This is another type of implantable cardiovascular defibrillators. There were 3 leads, as I said, in the right atrium, right ventricle, and the third one in the right ventricle, and the left ventricle, sorry. This is another example. They just said that this is have a single coil ICD system. This is for shocking, doesn't matter for us. The important thing is to look for the wires, if it is in position, and if there's any filling or incontinuity. What happened here is that, okay, so they have been entered through the subclavian vein and an electrode, also one of them in the right ventricle. This is, I think, called biventricular electrode. The important thing is when you differentiate between pacemaker and the implantable cardiovascular defibrillators, they have two coils and two ventricles, one of them the left, one of them of the right, while the pacemaker only in the right.
So if you see a coil on the left side, it's a defibrillator.
Mostly, yes, it is. This is a modified type of subcutaneous defibrillator. They put the shocking device or the defibrillators subcutaneously, and they put the wires around the subcutaneously, not reaching the heart. And it is not connected directly to the heart, but will provide a shock for the heart when it senses some sort of arrhythmia. This is a modified subcutaneous. Lastly, epicardial pacing. This is a procedure that we done temporarily before the surgery. A short way of organizing the heart function. It is called pericardial pacing. This is how these wires look like a hook, and they hooked in the heart. So this is the normal pacemaker, while this is the epicardial pacemaker. They just enter it from any pathway, and they put it in here, mostly in the ventricle system, to provide a shock for the heart temporarily for a short time before the main procedure. So this is with the three hooks around the heart. Also, one of the advantages on modified pacemaker is this small micro device that is wireless, also can provide transformally implantable through the femoral vein implanted reaching up here and into the apex of the right ventricle, and it will do its job by shocking the heart when it necessarily. Shall I continue?
I think we might stop here.
Yes, there's a lot of
Another
information.
session. طبعا يعني it's a really impressive job. Thank you very much.
Okay.
It's very well organized, very well presented. A lot of nice examples.